There are various different types of lines that are commonly used in intensive care and high dependency settings that you don't commonly encounter elsewhere. In this video, we'll be going through the basics that you should know about each of these different types of line. Firstly, let's start off with peripheral venous cannulas. You're likely to be very familiar with cannulas, but I'd just like to make one point about the sizing of cannulas. On the smaller end of the spectrum, we have yellow 24 gauge cannulas, and at the bigger end, we have orange 14 gauge cannulas. We have blue, pink, green, and grey in between. The flow through a cannula, as with any other tube, is governed by a principle known as Poiseuille's law. It links flow with pressure difference, fluid viscosity, and the radius and length of the tube. You don't need to remember the exact formula, but the important point to recognize is that in this equation, the radius is increased to the fourth power, meaning that doubling the radius of the tube will increase flow by a factor of 16. When relating this back to cannulas, a yellow cannula has a flow rate of about 20 mils per minute, whereas an orange cannula can achieve a flow rate of around 240 mils per minute. The take-home point is that the flow rate increases dramatically with each step up in cannula size. Therefore, it's important to use larger cannulas in patients who are likely to need rapid infusions, for example in trauma patients with massive blood loss. A midline is essentially a very long cannula that is inserted into the basilic or brachial vein. It's used in patients with poor venous access or those in need of long-term antibiotic therapy, as it can stay in place for 4 weeks. It's generally quite a safe type of line to insert, however risks include bleeding, extravasation, and thrombosis. A peripherally inserted central cannula or PICC line is a long line that is inserted into the basilic vein with the tip being ideally positioned near the right atrium. Like midlines, it may be used in patients with poor venous access who are needing long-term IV access. As it's a form of central line, it can also be used to administer irritant medications and TPN. Complications include infection, bleeding, and occlusion. As the process involves inserting a guide wire towards the central venous system, it can also irritate the myocardium and cause arrhythmias. Central venous lines are very commonly used in ITU and are essentially a form of large cannula where the end sits in the vena cava. They can be inserted via the internal jugular, femoral, or subclavian veins. Common indications include administration of high-dose presses and irritant medication. They're also useful when multiple infusions are needed, for central venous pressure monitoring, and for blood sampling. Complications associated with central venous lines include pneumothoraces, bleeding, infection, thrombosis, and air embolisms. They can usually only stay in place for 7 to 10 days at a time due to the risk of infection. Vascats are a type of central venous line which has a large bore and may have 2 or 3 lumens. The key difference between Vascats and other central venous lines is that it has a large bore, allowing higher flow rates. It's usually inserted into the internal jugular or femoral veins. It's used for hemofiltration in ITU, but it can also be used for blood product exchange, for example, red cell or plasma exchange. The insertion of a Vascat is similar to other central lines, and so the complications are also similar. Finally, an arterial line, as the name suggests, is a form of line that is inserted into an artery. It's most commonly inserted into the radial artery, but can also be inserted into the brachial and femoral arteries. It's useful in ITU for continuous blood pressure monitoring and for regularly taking blood samples. Patients in ITU have regular ABGs and various other blood tests for monitoring purposes, and the arterial line is a convenient way of obtaining these samples. As arteries have a much faster flow rate than veins, there is a much lower risk of infection compared to central venous lines, and hence they can remain in place for much longer. There are a few other complications to be aware of though, such as hematoma formation, thrombosis, dissection of the artery, and the formation of pseudoaneurysms. This is what an arterial line trace will look like. The peak is the pressure during systole, the trough is the end diastolic pressure, and the distance between the two is the pulse pressure. The small notch seen on the downstroke is referred to as the dicrotic notch. This is caused by closure of the aortic valve, causing brief reverse flow and a drop in pressure. Then, once the valve is fully closed and blood flow stops momentarily, the elastic recoil of the aorta causes a small rebound. Another term that you will often hear in relation to arterial line traces is swinging of the trace. This refers to the variation in amplitude of the waveform with the respiratory cycle. It's associated with intravascular volume depletion and will vary depending on whether the patient is spontaneously breathing or mechanically ventilated. The exact mechanics are complicated, and I have attached a link to a YouTube video that explains this clearly if you're interested. For the purposes of this session, you just need to appreciate that if the patient is intravascularly deplete, their systolic blood pressure will drop during mechanical expiration and it will drop during spontaneous inspiration. The main reason being that the intrathoracic pressure is higher during inspiration in mechanically ventilated patients and higher in expiration in spontaneously breathing patients.